to talk about respiratory failure. This topic is actually very basic and fundamental in medicine, but it contains a lot of essential knowledge. Because of that, many students get confused by how broad this category is. So today, my goal is simple. I want to give you a clear mental picture of respiratory failure, so you can understand what is happening in your patients and connect physiology directly to clinical care. First, let's start with the definition. Respiratory failure is defined as a PaO2 below 60 mm Hg on room air. In their clinical practice, this roughly corresponds to an SpO2 below 90%. When you see a patient with hypoxia, you should always evaluate respiratory failure using two axes. The first axis is acute versus chronic. Acute respiratory failure develops within days to weeks. Chronic respiratory failure develops over months or longer. This distinction is important because it affects both physiology and management. The second axis is type 1 versus type 2 respiratory failure. Type 1 respiratory failure is hypoxia without CO2 retention. PaCO2 is normal or low. Type 2 respiratory failure is hypoxia with CO2 retention. PaCO2 is elevated. A classic example of type 2 respiratory failure is COPD. Common causes of type 1 include pneumonia, ARDS, and interstitial lung disease. Next, let's look at the mechanisms. This is a very high-yield topic for exams and extremely important in emergency and critical care. When you find hypoxia, the first question is whether this is truly respiratory failure. Once confirmed, the causes can be divided into two large groups, whether a gradient increase or not. The first group is gas exchange failure. This category includes three mechanisms: VQ mismatch, diffusion impairment, and shunt. I explained these mechanisms in detail in my gradient DO2 video. So here I just give you the core idea. In VQ mismatch, ventilation and perfusion are not properly matched. In diffusion impairment, oxygen cannot cross the alveolar capillary membrane efficiently. In shunt, the oxygenated blood mixed with oxygenated blood, which lowers arterial oxygen levels. If we want to understand how to differentiate these mechanisms using AADO2, please check the separate video. The second major category is ventilatory failure. There are two main mechanisms. First, reduced respiratory drive or respiratory muscle weakness. For example, drug overdose, neuromuscular disease, or severe fatigue can reduce minute ventilation and cause CO2 retention and hypoxia. Second, airflow limitation. In disease like COPD or severe asthma, CO2 cannot be exhaled effectively because the airways are narrowed. As a result, PaCO2 rises and PaO2 falls. Now let's talk about how we use arterial blood gas analysis. If PaO2 is below 60, the patient meets the criteria for respiratory failure. Next, check PaCO2. If PaO2 is elevated, this is type 2 respiratory failure. If PaCO2 is normal or low, this is type 1 respiratory failure. After that, whether the condition is acute or chronic. I explain pH interpretation in detail in another video. So here I just give you the clinical framework. In type 1 respiratory failure, acute cases often show respiratory alkalosis because hyperventilation or gas before compensation can fully develop. Chronic cases tend to have a near normal pH due to compensation. In type 2 respiratory failure, a normal pH suggests chronic type 2, a low pH suggests either. We check bicarbonate here, acute type 2 or chronic type 2 with acute exacerbation. To differentiate these, bicarbonate levels are helpful, and I explain that step by step in my ABG arterial blood gas analysis video. Now let me ask you a question. Patient has SpO2 below 90%, CO2 level above 50 mm Hg, pH below 7.3. What is happening in this patient? PaCO2 is elevated, so this is type 2 respiratory failure. pH is low, indicating acute decompensation. But let's check bicarbonate here. If bicarbonate is elevated, this suggests chronic type 2 respiratory failure with acute exacerbation, such as COPD exacerbation. This framework is essential for understanding respiratory failure. It may feel complicated at first, but once you connect gas exchange, ventilation, and ABG interpretation, everything becomes much clearer. If parts of this were difficult, please check the AA gradient and ABG interpretation videos.